Thank you, chairpersons, and thank you to the organizers. This meeting has become like a habit coming here every year, and I quite enjoy this habit. So I'm going to be slightly more restricted compared to what Dr. Arvind was. I'll talk to you primarily about AI and diabetic retinopathy. Let me just start on this. These numbers really have been repeated and will be repeated frequently. We're looking at a country with 100 million people with diabetes, but that's one point. I think the other issue of importance here is that prevalence of any diabetic retinopathy, and this is work done by the chairpersons and many other colleagues across, is about 16% or 12%, but the prevalence of sight-threatening retinopathy is about 4%. That means about 4 million people have sight-threatening retinopathy. How many ophthalmologists are there in India? 30,000, right? So I think we just have to put the context. It's not that whether AI is good or is bad. I think we need all the help from any source and any method and any process to enhance our ability to identify people at risk and intervene. And I think that is the key message, which we just don't have the suitable man or woman power alone to do this manually and repeatedly in our population of people with diabetes, right? And if you look at the recommendations for screening, the standard recommendations of the frequency of screening, but these are the more recent recommendations from the American Diabetes Association, which clearly endorse that programs that use retinal photography with remote reading and are approved by the FDA can be used for this purpose. So there is a general endorsement that this is an additional method of trying to identify people with retinopathy. Now, one of the earliest papers actually was published about 10 years ago when deep learning was used to develop an algorithm. This is actually work done by the team at Google. And this was, again, it shows, as Dr. Arvind mentioned, it's very laborious. You need a lot of people working over integrating a lot of images and then running the algorithms, and then after doing a discovery phase, ending up with validation. And as you can see that it performed reasonably well, 90 plus sensitivity, 90 plus specificity, and the issue, of course, initially was that the camera used, and therefore the concern was whether the image quality used to develop this algorithm was dependent on very high quality images using high-end cameras. But as mentioned recently, there has been a progressive transition that relatively less expensive cameras have been used to generate algorithms and also to develop a software as a medical device to identify and screen for diabetes. I will use the word screening repeatedly because it's not a diagnosis, and I think we need to distinguish between what AI is doing and what the ophthalmologists do. And for me, the primary and the most important purpose of a tool like AI is to actually just differentiate that human being sitting across into two categories: to go or not to go to an ophthalmologist, who will then take care of the therapeutic part, because it is very, very important not to believe that the AI is the end point out there, right? So for me, it's a screening tool, which is very, very important to understand. Again, there are similar studies in India, and I think there was a very nice compilation shown by Dr. Arvind, and this again showed 90 to 95% or even higher sensitivities and specificities. So really suggesting that it's not only under highly controlled environments, but even in real world settings, you're getting fairly good results to be able to endorse that this is a methodology for doing the work. And there are several FDA approved tools. Some of them are available exclusively in the US. We heard about the Remedio tool, which is approved as a software for a medical device by the CDSCO. I just wanted to again reiterate, I just told you that about 25 to 30,000 ophthalmologists, and the number of vitreoretinal specialists is actually a 1/10 of that. So you're really looking at a the funnel of available manpower to actually treat is actually very significant. So you do not want to overload that manpower into doing activities like screening, which can be offloaded to less to less trained individuals, right? So what are the key functions of AI and diabetic retinopathy? Would obviously be screening, to some extent being classification, but that of course will be validated by the treating ophthalmologist. And I think the other word which is important is triage. So if you see something which is clearly which is sinister, you need to be able to show alacrity in referrals rather than say, you should go and see an ophthalmologist and they will take care of it as and when you go. So I'm going to sort of briefly share two pieces of work which are done at AIIMS. One, of course, is work done between our ophthalmologists and the Wadhwani AI Foundation. So Wadhwani AI is a group which is involved in sort of computer vision, and this was work which was, I would say, catalyzed by the Ministry of Health, and the Wadhwani AI team is actually a partner for the Ministry of Health in this particular effort. In addition to AIIMS, there are the AIIMS New Delhi, there's AIIMS Rishikesh and other institutions also. And so an indigenous model was developed, very similar to what was described by Dr. Arvind by other Indian commercial entities. And the primary aim of this model was to essentially say, this individual needs to be referred or this individual need not be referred. You can reassure the individual that, you know, all is good. You don't have to go running to an ophthalmologist. We'll see you in a year or a couple of years as required by this. So this is the usual thing. Patient workflows was capturing images using a non-mydriatic fundus and phone camera, and then differentiating individuals to a referable or a non-referable state, and then the ophthalmologist referral was taken care of. Just to give you a sense of numbers, again, this is how you would normally do it. You would see prediction by AI, yes, no, and gold standard would be that by an ophthalmologist, obviously, and a yes, no. And you can see that the sensitivity and specificity of this model was actually pretty good, 96%, 98%, with a positive and negative predictive value of 96 to 98. So really it means that if you're able to tell somebody you don't have retinopathy which requires referral, you're nearly right on every single occasion except 2 out of 100, which is pretty good going, right? The challenges and limitations always will be that image quality will be contingent on lots of things, and therefore there will be non-readable images on several occasions. And that will happen whether you're using AI to evaluate the fundus image or whether you're using a human eye to do that. Often the ophthalmologist can overcome some of it because of their skills and dexterity. You could have false positives in coexisting diseases like hypertensive retinopathy and vascular exclusions. You, at the moment, unlike what was mentioned by Dr. Arvind, most available algorithms are restricted to diabetic retinopathy, and they may not be able to provide you information about concurrent or additional glaucoma or age-related macular degeneration. But obviously that's something which is important. And there are legal and regulatory ambiguities. In addition to what is going on, the WHO has just recently constituted a working group about the legal aspects of the use of AI in medicine, not just in computer vision, but overall. And I think this is an area which is of great importance, because eventually, putting it in a litigious society, the question will always be, if something goes wrong, who is to blame, right? And that is a question which needs to be referral. At the moment, eventually it'll be the most proximate caregiver. So if I'm the person who is advised care based on an algorithm which somebody else made, I am the person who's most proximate to the delivery of care, and therefore the burden will fall on me to justify what I did. I mean, that's the prevailing belief, but it hasn't yet obviously got converted into a legal framework. And just like you were shown, this is the license for the AIIMS, but remember, this is a little earlier stage than what was shown. This is a license to manufacture to test and not a manufacturer to use as yet. But clearly, this is the sort of stuff which may be required by the government to roll out in public health settings, because it then becomes a non-licensed product which is free of cost. The other small study that we were involved in, most of the work done in AI for diabetic retinopathy has been for looking at it's been agnostic of the type of diabetes. But the ophthalmologist will tell you that the fundus photograph of younger eyes sometimes add a degree of complexity for the AI, because there's a concept of a retinal sheen which may then impact the way the algorithm reads the eye. And for this reason, we actually, this is work done by us in the Department of Endocrinology at AIIMS. This was done with the Google ARDA, which is their AI, and the system integrator involved in this particular case was another Indian company, which is Forus. So basically what happens is that you take an image, the image goes to a certain place, the system integrator then ensures that the image is transferred to the cloud server which holds the software, and then the answer comes back to you, right? So that's the use, unless and until the system integrator is also owned by the person who runs the particular software. So this was done in the department, and again you'll see that we used young onset type 1, young onset diabetes, and then we further subdivided those into a younger and an older cohort of those who were up till 25 years of age and those between 25 and 45 years of age. And again, what we did find was, and I won't go into actual numbers, that it performed reasonably well in the same 90 plus numbers, except when it came to the sensitivity for diagnosing diabetic macular edema. And that possibly is because it's the same algorithm and the same software which works well in older eyes, but clearly extending it to younger eyes and the architectural issues of younger eyes possibly added this particular problem. And it was just important for us to therefore understand that you shouldn't extrapolate information or data generated from one particular set to another set of eyes. And this is important additional information, and obviously we need to do some more work about that. Before I sort of come to the very last bit, it's important to see how we as average diabetologists, endocrinologists would like to incorporate AI into our practice if we do so, and why do we actually need it? And I think I come from a hospital where my outpatient clinic has shifted a little bit, but previously the actual distance between my outpatient clinic and a center which is a 7th-floor center of ophthalmology exclusively was 50 meters, right? That was a distance which the patient was expected to travel from my clinic to that clinic. I think 70% of them did not make that distance, right? So the issue is, how do you ensure that a patient who should be seen by an ophthalmologist because they require ophthalmic care reaches the ophthalmologist? The prevention of retinopathy is ours to do. As treating physicians, diabetologists, endocrinologists, we need to keep the parameters fine. But if we are unsuccessful in doing that and we need ophthalmic colleagues to do the needful, how do we ensure that this human being goes from us to the person who is skilled and empowered to do so? And that is perhaps the most important question to be answered, because once they reach the ophthalmologist, they will do their job, right? So for us, if you want to be a part of this crusade, you actually need to purchase a fundus camera. Fortunately, as mentioned by Dr. Arvind, from the time when high-end cameras were, touch 40, 50 lakhs, you can actually get away with much cheaper. Training a multi-purpose worker to actually take the image is really not an issue. You just need to be trained. It can be done. You don't need, highly sophisticated manpower to do that. Several Indian companies, we've heard of Remedio, we also had Forus, they have the AI functionality already available in their devices. So you really don't have to go into anything very complicated. And then the critical issue is to refer the patient who needs care to an ophthalmologist. So what have we been doing in addition to this is just to give you a sense, and I'm not saying that you should do this. So, and most of my work has been primarily in the age group which is young, so youth onset diabetes. So the first thing was to actually start creating a repository of photographs which are sequential of the same patient, which is annotated and which also relates back to their various clinical, demographic, and biochemical parameters. It's like you're not treating a photograph of the eye. You're treating an individual, and therefore the additional information which that individual has to offer, if that is combined with the photograph of the eye, your ability to treat becomes that much better. So what we do is, we've now, fortunately, we have an in-house, we call it a computer facility. The computer facility has made for us software with our interaction. When a photograph is taken in our clinic, it gets uploaded onto the software. The ophthalmologist has a separate login. They can log in at their convenience when they want to see. They can then give their grading, and then they post that grading onto the same software, which is visible to us by the time the patient comes back to see us. Obviously, if there's an urgent requirement, so that's non-AI. Just to be very clear, this is non-AI. This is a mechanism by which we are ensuring that the patient does not have to go to the ophthalmologist unless the image shows something that they require ophthalmic care. Now, it reduces the burden on the patient. It does not reduce the burden on the ophthalmologist. It just gives the ophthalmologist more flexibility, that they don't have to sit in the clinic and see the patient. They're seeing images which they can come back to us. Right? So at the moment we're doing a small randomized control trial, and hopefully in one of the future editions of this meeting we may be able to present that. And it's essentially a very simple question being asked: what is the effectiveness of 3 different strategies to ensure that a person who should have reached an ophthalmologist reaches the ophthalmologist, right? And so it's a 3-arm study which has essentially, the first arm is plain and simple what we used to do, and actually still continue to do in the absence of all of this, is to see a patient and say, you know, it's been a year since somebody has seen your eye. Go and see somebody who can see your eye, because I was just telling Ranjit, half of the doctors today don't know which is the right side of the ophthalmoscope which has to be pointed towards the patient, and which is the side which is to be looked by them. The other half have lost their ophthalmoscope, so that leaves you with 0 people who can do any direct fundoscopy, right? So that's one group. The other group, the photograph is taken, and then the patient is told, we will send your photograph across to an ophthalmologist. If need be, we will inform you. You can then go and see the ophthalmologist. And the third arm is, we take the photograph, run the AI, and immediately give feedback to the patient saying, all is well, nothing is to be done, or something seems to be amiss, we need you to go and see the ophthalmologist. And the primary outcome is actually fairly simple. It's the percentage of participants who have actually seen the ophthalmologist within 3 months of that particular visit in the clinic, of those who should have gone. So in Arm A, if you see 100 people, all 100 were sent to the ophthalmologist because nobody screened them. In the other arm, those whose image was graded manually later were sent. And in the third arm, we had the luxury of reinforcing the need for a referral while the patient was still in the clinic, with the belief that if we can do that counseling and referral backed by the image, as Dr. Arvind said, if you can show the blood in the eye, you are in a better position to convince them to go and see the ophthalmologist. In the first instance, all 100 patients will go to the ophthalmologist because everybody is eligible. In the second arm, let's say 20% of people have retinopathy, so only 20% will go. So the physical footfall in the ophthalmic office declines, but the workload of the ophthalmologist does not decline, because they have to either see the image or the patient or both. And in the last category, the workload of the ophthalmologist declines, and because the patient is already informed, and if there's only 20% of patients, so the ophthalmologist will not see 80% of patients or their images, they'll only see 20% of patients and their images. So let's see what happens when by the time we finish it. So I think we are moving from detection to prediction, not only predicting heart attacks, but also predicting retinopathy and predicting other ophthalmic problems. And I think that's a great thing to be going. Involving and incorporating other stuff may help in prognostication. So there are multiple things happen. Of course, we've heard about what multimodal AI models, which will do a lot of things in addition by incorporating additional information, incorporating other functionalities to be able to assist in our efforts to make the patient. So now I will stop here, but I will be remiss in my job if I don't thank a whole bunch of colleagues within my department, within the Dr. Rajendra Prasad Center for Ophthalmic Sciences, which with their retina team, a lot of optometrists, research staff, the computer facility at AIMS, biostatisticians who are critical for mathematically illiterate people like me when it comes to looking at data, the Google team which was involved in one of the particular studies, and of course the funding agencies. Thank you so much.